the surgical aspect has been discussed. My talk will be basically on, it's a comprehensive thing. Basically, it's a multidisciplinary thing, which is the most important thing in the bladder cancer. So I'll just be dealing with the benefits of neoadjuvant and adjuvant in these group of patients. So the burden of cancer, as we say, in India, it is what we see is the highest incidence in the bladder cancer is of the China. India comes sixth throughout, and around 17% is the leading cause of cancer in India. Is the 17th position of bladder cancer, and 21st in the mortality. But the important point is the presentation. Though the presentation in our setting, it is most patient with present with a non-muscle invasive bladder cancer is around 47%, as compared to the West, where the most patients are carcinoma in situ or other in this group of patients. Along with the metastatic cancer in our setting is 17% as compared to only 5% in the West. So this is the wholesome slide which will be discussed, I think so, in today's preceptor session, and it incorporates everything, right from the non-muscle invasive bladder cancer patients to the muscle invasive and metastatic. So how in the non-muscle invasive we go with a TURBT with intravesical therapy, and thereafter, if needed, a cystectomy or a pembrolizumab, which has already been discussed. The muscle invasive one, which is the stage 2 and 3 cancer, that is invading muscle or the perivesical fat, and based on that, whether it's a cisplatin eligible patient or ineligible, and then to go for a neoadjuvant therapy or a radical cystectomy upfront in this group of patients, and the role of trimodality, if even after neoadjuvant or post radical cystectomy. And the metastatic part, which will be discussed later, so I'm not going at present in details. So this is the approach to the initial therapy for the muscle invasive bladder cancer. We say, if the patient is in stage 2 or 3, if it's a patient is a surgical candidate and willing to accept radical cystectomy, in that case, you have to look whether he is cisplatin eligible or not. If he is a cisplatin eligible, go for a neoadjuvant cisplatin based chemotherapy followed by radical cystectomy. But if it's not a cisplatin eligible, there is no chance, go for a radical cystectomy or intramodality therapy based on the multidisciplinary tumor board. But if he is not willing to accept radical cystectomy upfront, in this case there is no option, you have to go for a bladder preserving trimodality, that is TURBT, as already discussed, followed by concurrent chemoradiotherapy in this group of patients. So the multidisciplinary team is the most important, I will say. The optimal management requires not only the patient, the family, urologist, medical oncologist, the pathologist, radiologist, and the supportive care, and a good communication and the side effect profile that has to be discussed in this group of patients. So the patient should feel that they are very much well informed about their disease, what are the outcomes and what are the treatment and what is the best they are going to achieve with that. So the efficacy, if we go with a radical cystectomy alone, so why the talk about neoadjuvant and adjuvant? Though it is an excellent and unparalleled local control is given with this radical cystectomy, but with the most effective rates of cure. But if you see, if the disease, the 5-year disease-free survival, if it is organ confined, that is only limited to the bladder, the 5-year survival is 65-25%. But if there is an extravesical spread, this survival decreased to 35 to 65%. And if it's a node positive, the survival comes down to 30%. So even with radical cystectomy, at least 35% of the patient will going to die of their disease if they are going with only radical cystectomy. So we see that it's based on their survival, whether it's organ confined or extravesical or lymph node, the outcome depends on that. So perioperative chemotherapy is simply intended to eradicate all these subclinical disease and improve the OS. So the options, as we see, is muscle invasive is not only radical cystectomy, neoadjuvant chemotherapy, but also radical followed by adjuvant and the bladder sparing strategies. So all these are options, and these options has to be explained to the patient upfront and along with their pros and cons. So if we see that how the clinical data are emerging, so if we see for NSAT, if the performance status is very good with a good GFR, you should go with a neoadjuvant followed by that. But if a performance status is borderline, that is 2, with a low GFR, surely radical cystectomy or a trimodality. With a poor performance status, with a low GFR, a trimodality or only radiation is the option. And post this, you may have considered for, we need a adjuvant therapy, which means you may choose for an immune checkpoint inhibitor or a standard cisplatin based on the earlier treatment the patient has received. So if we see the outcomes at 5 years after neoadjuvant chemotherapy and cystectomy in these patients, the 5-year OS goes to something around 50% versus 45% clearly in one study, which shows the absolute DFS benefit of around 7%. So in the absence of a, basically we say a definitive standard of care, the different chemotherapy modules which we see, the dose tells impact in young patient with good PS and no comorbidities, it shortens the time from diagnosis to surgery. So that is the preferred modality. In older patient and those unable to tolerate this combination due to medical comorbidities, gemcitabine cisplatin is a reasonable alternative. And those even with a creatinine clearance between 50 and 60. So in that case, the cisplatin dose you have to split in day 1, day 8. So that's the thing which has to be taken care of planning treatment in these group of patients. So what are the data about this effectiveness of neoadjuvant? So the first data came from the retrospective studies, which shows that even after giving the MVAC or gemcitabine, what is the PATH-CR rate is going in the order of around 31% with gemcitabine cisplatin, whereas with the MVAC this is something around 29%. So something around 30% of the patients is even in the retrospective analysis of data that is not in a trial setting is showing a PATH-CR rate to this group. But the important question is, why aren't the eligible patients still receiving neoadjuvant? So basically the study went from one is from the US. It clearly shows that only 17% of eligible patients are somehow receiving neoadjuvant. Because the urologist's concern is there that who will going to benefit? What is the risk versus benefit? It will further delay cystectomy, that is more than 3 months will be delay, whether it will lead to an adverse outcome, or what are the toxicities of chemotherapy in the form of renal impairment or wound healing or reduced performance status after chemotherapy. That are the things which has to be taken care. So even in the Society of Uro-Oncology, it has been said that the middle-aged patients are the most who have gone for the neoadjuvant chemotherapy, and those with the advanced disease T3, T4 have maximum gone for this neoadjuvant. And the reason given by the media why they haven't said is the age and comorbidities, delay in surgery, there is a marginal benefit, prolonged diagnosis and referral, adjuvant therapy may have an also effect, so why to go for a neoadjuvant, and there are further risk of surgical complication. So this graph clearly shows that the person, there is only a minor in the last 2 decades, I will say that only a marginal patient going for the neoadjuvant therapy despite its showing benefit. So the studies which supports this, that the neoadjuvant, we say the first study is the phase 3 trial of which use the methotrexate, vinblastine and cisplatin. And it clearly shows that in the patients who have received 3 cycles of this therapy, the hazard rate is 0.84, that is 10 years survival, there is a 6% benefit in this 10 years survival in this group of patients. So if we see with the MVAC followed, the next study is the MVAC, which followed by radical cystectomy. And this study which is published in NEG of 2003, and that has shown a marked difference, that if you are going with an MVAC followed by cystectomy, the median OS is 77 months as compared to cystectomy alone, which is only 46 months. So there is a definite benefit of neoadjuvant MVAC if we are given, followed by radical cystectomy as compared to immediate radical cystectomy in this group of patients. Thereafter came the meta-analysis. So this meta-analysis clearly shows that in the earlier studies which have used neoadjuvant only as a cisplatinum or the platinum as the agent, they haven't showed a benefit as a neoadjuvant intent. But when the combination therapy is used, so in different studies all the platinum-based combination have used, so they have clearly shown a hazard rate of 0.89. The first plot is clearly showing that with a combination therapy, the neoadjuvant is better as compared to a single agent cisplatin initially. So again came the phase 2 trial of accelerated MVAC, and post this accelerated MVAC, it has clearly shown that during the treatment, around 65% of the patient have a downstaging of the tumor, 18% upstaging with no change in 17%. And if we say that the CR complete rate is 38%, T0 is we are getting in the pathological response in 38% of the patients, if you have starting with this therapy. And the important thing is what happens. So the patient selection is the most important in the patient response also. So if a patient has got a pathological CR, the relapse-free survival is too high as compared to without pathological CR. And if you see an overall survival, the p-value is 0.04, and if a patient have a pathological CR post-neoadjuvant, they have got a very long overall survival. So it's a completely straight line as compared to a patient who hasn't achieved a pathological CR. So thereafter came the dose-dense MVAC study with pegfilgrastim. And what it has shown that even after 4 cycles of dose-dense therapy, the patient who achieved pathological CR is around 26%, and those who has downstage to less than T1 is around 49%. So 50% of the patients have gone downstage, and 82% of the patients who are node positive also became node negative after the treatment with this. So, and no patient who have got node negative has developed any node positivity after the treatment with the dose-dense MVAC. So the pathological downstaging, if we see, is greatly depends on the how does the patient behave and what is the cure rate. So if you see the cumulative survival of any patient who has a P2 and 0, that is in the path CR, the survival is too high. So it's mostly a straight line we see, and as the response decreases, the survival decreases in this patient. So if we see the 5-year OS of the patient who is less than PT2 is 90%, as compared to the patient who is the post chemotherapy, the disease is still pathological T2, the 5-year OS is 37%. So it all depends on the response the patient is having, and the survival depends on that in this group of patients. So the MVAC followed by radical cystectomy clearly showed that if the patient is receiving MVAC with cystectomy with the PT20, the survival is not reached in this. With the cystectomy alone, it is 11.3. But if even after MVAC and cystectomy, if there is a residual disease present, so the median survival is only 3.8 months. So the most important thing is how does the patient is responding to the chemotherapy, and that clearly leads to how long the patient is surviving with that. Thereafter came the GetUp trial, which shows they have compared because dose MVAC has got its own toxicities, so they have compared with gemcitabine cisplatin in the patient with muscle invasive bladder cancer. They have either used 4 cycle of gemcis as compared to the 6 cycle of dose MVAC every 2 weekly. And what they see, the pathological response rate, that is the CR rate with the gemcis, is also around 36% as compared to 42% of the patient who have received dose MVAC. So this drug is also showing a very good response. Around the adjuvant therapy, we say only 11% of the patients have received in this trial adjuvant therapy, and maximum patient 90% have received neoadjuvant in this. So all patients, this is a compared with the gemcis, dose MVAC had a similar 3-year PFS, that is around 64 versus 56 months, and improved time to progression, that is around 69 versus 58%. So if we say that dose MVAC improved the 3-year PFS as compared with gemcis, dose 66 versus 56%, the patch CR rate is not much different in this agents, and dose has the important thing, the local control rate. It is still, we'll say it's higher, that is 63% as compared to the gemcis in these group of patients. And overall survival is also more or less, we will say, similar in both, but the grade 3 toxicities are clearly higher with the dose MVAC. So when to start the therapy, that is the most important thing. So there is another study which shows that once after diagnosis, if you delay a treatment starting neoadjuvant of more than 8 weeks, so it has got a bad effect on the disease biology, and the patient may progress earlier. So a delay of more than 8 weeks increases the risk of upstaging. So one have to, after diagnosis, start the neoadjuvant upfront, and it is important that the patient even after chemotherapy go for radical cystectomy within 7 months from the initial diagnosis. These patients do much better than those who are further delayed. So, what are the factors which lead to how to detect that the patient is going to respond to a neoadjuvant chemotherapy? So now it's the era of NGS testing and the biomarker testing. So there are few biomarkers which need to be determined, which will be surely coming in the near future. So like the mutations like ERCC2, if it is present, it is clearly associated with pathological response. So in different studies has clearly shown that ERCC2 mutation is associated with improved overall survival in different patients. Whereas with other mutations like ATM, RB1 or FANG, it is also associated with an improved response in the case of big downstaging of the tumor. And other is the HER2 mutation, the RB2 mutation, if it is present, it is also associated with a good response. If the patient is having a DDR gene alteration, what's the DNA damage response alteration? So these are also the patients who are going to have a better prognosis with the treatment in this group. And the basal tumors has benefited the most from neoadjuvant chemotherapy as compared to all others. So what do we see? How can we predict the response to neoadjuvant? So if you are saying getting an ATM, RB1 or FANG, so these patients are the best who have got the best response, the best CR rate, complete. The overall survival is the best for these patients as compared to those who doesn't have this response. So dose then gemcitabine cisplatin has also been tried in a patient with this DDR, DNA damage response genomic alteration. And if this DNA damage response alteration is present, the relapse-free survival is very high for these patients as compared to those who are wild type with this. So genomic picture is also have a huge part in this now. So there is another trial which is now coming, which is initiating neoadjuvant chemotherapy, that is the retained bladder, that is post TURBT, you give an MVAC 3 cycle, and thereafter you do a repeat TURBT and see if there is any residual tumor. No residual tumor, patient going for active surveillance. If there is a residual tumor, it's the patient and physician's choice depending on the stage, whether it's T1, T2 or T3. So in the T1, we go for an intravesical therapy or chemo RT or cystectomy, but for T2 it's a chemo radiation or cystectomy, or T3 is a cystectomy. So they have kept the primary endpoint as a metastasis-free survival in this. And what we have seen that the metastatic free survival with this risk adapted design is around 78% as compared to the standard of care of 64%. So now in bladder cancer, you have to risk stratify even after treating the patient, and then you have to get other trials which have taken in consideration this gemcitabine nivolumab in comparison with the biomarker with ATM FANC or AL2. So if the patient has received this 4 cycle, the registration trial, and thereafter if re-staging imaging is done, so you see the patient is, if there is a very good response, you may have to go for a cystectomy, or if the patient is being classified into nivolumab or cystectomy if these mutations are present, and then the outcome is being seen in this. Similarly, the other dose gemcitabine, we have taken the DDR, we have discussed. So how in the future the patient is going to treat for the MIBC? So it is not the TCGA classification which is coming in picture, and that takes the luminal or the basal squamous subtype. So if then we see, so though it's in, I will say next in 2 to 3 years we are doing NGS for all the patients, and the genomic profile is coming. So this will help us to know how the patients are responding. If it's a luminal papillary type with FGFR3 mutation, fusion amplification, or a papillary histology or low CIS, these patients are going to, there is less likelihood of they are responding with neoadjuvant chemotherapy. FGFR3 inhibitor is the way to go for these patients. For those with luminal infiltrated, that is with low purity EMT markers, that is a epithelial mesenchymal tumor transition markers, or with PD-L1 positivity. So these are the patients who are more responding with the immunotherapy as compared to chemotherapy. So we have to take it. And for the luminal type, one have to see the target and then plan accordingly. For basal squamous cell type, so a female squamous differentiation, basal keratin present, so that maybe go for more with a neoadjuvant chemotherapy along in combination with immunotherapy. Whereas for the neuronal type, it's still the depending on the markers you are present, so it may be a neuroendocrine differentiation, and you will go for a hydroposis like neoadjuvant chemotherapy as other. So completely, we divide the patient in bladder cancer also based on the genomic profile. So you have to divide, and the treatment depends on whether the patient go for a chemotherapy or a targeted or a immunotherapy. In the neoadjuvant, you have to see that. So there are many trials with a neoadjuvant, and 2 results are still out. That the Pembro trial with POR1, which has shown a PAT-CR rate of around 30 to 40% in the neoadjuvant intent, and the Abacus with Atizo, which is also showing around the PAT-CR rate of 30 to 40% in this group of patients. The last one with gemcitabine with Nivo, chemoimmuno, has showing a PAT-CR of 50% in this group of patients. So this is the trial which is compared Pembro with others. So what we in this trial has shown that the response